Hello, I'm Mimi Suzuki, a doctoral fellow at this institute based at City St. George's University of London. Today, I'll be talking about my PhD project, which explores how mental health practitioners make referral decisions for people presenting to emergency departments after self harm or suicidal thoughts. At its core, my research asks how systemic pressures shape what happens when someone in suicidal crisis seeks help in emergency care, and how these pressures unfold in practice, in talk, and in patient experience. To make sense of this, I often think of the work of practitioners as a kind of craft, something that relies on skill, clinical judgment, and sensitivity to the person in front of them. But this craft doesn't exist in a vacuum. It's carried out within systems driven by targets, risk protocols, and limited time. It's a bit like asking a tailor to make clothes that fit each person perfectly, but giving them only three standard patterns and an hour to finish each garment. The tailor's work becomes mechanical. The person must fit the pattern instead of the pattern fitting the person. That's what it can feel like for mental health practitioners in emergency care. They want to tailor the care to the individual, to listen and adapt, but systemic pressures demand speed, standardization, and measurable throughput. My research explores what happens in this space between craft and constraint, and what it means for practitioners trying to provide care that truly fits the person in front of them. Self-harm is the strongest predictor of later suicide, and every year over 200,000 people present to the emergency department after self-harm at a cost of around £162 million. Psychosocial assessments conducted by mental health liaison teams are meant to identify need and risk and match people to appropriate care, admission, referral, or discharge into the community. In principle, this should be a person-centered process. But in practice, many patients leave without meaningful follow-up, and suicide risk remains highest just after discharge. So something about how referral decisions are made and communicated isn't working as intended. Patients talk about services as a fortress designed to keep people out, while practitioners describe an exclusion culture where access depends on diagnosis, threshold, and system capacity. We know what the problem looks like, but we don't fully understand how these systemic pressures shape the real-time practice of making decisions. How do practitioners adjust their clinical craft within institutional limits? To understand this complexity, my research treats referral decisions not as a single clinical judgment, but as systemic and communicative processes. I explore them through three interlinked questions. Firstly, looking at context. What is the context these referral decisions are made in? Communication. How are these decisions talked about during the psychosocial assessment? And what does person-centered care look like in practice? And the journey. What happens to patients afterwards? How do they experience their journey through the mental health system after discharge? Together, these connect structure, process, and outcome, showing how wider systems shape what happens in individual encounters. To explore context, I conducted 167 hours of ethnographic observations, shadowing two liaison teams, one in a hospital emergency department and one in a mental health crisis assessment service, MHCAS. Essentially, this is a mental health emergency department. The key differences in these two settings is that the hospital emergency department operates under intense time pressure, including the 4-hour target to admit, transfer, or discharge patients, whereas MHCAS is not bound by these targets. This means patients there often have more time to decompress, and practitioners can work in a calmer environment. Across both settings, however, decisions about aftercare are not purely clinical. They were influenced by the limited availability of aftercare options in the community, strict service thresholds and eligibility criteria for services that did exist, pressure to discharge patients within time targets in the hospital emergency department, and to maintain throughput in the MHCAS. And there was a shift in responsibility of care and liability between organizations. Practitioners often described feeling like brokers rather than clinicians trying to fit complex people into rigid pathways. These structural pressures gave rise to risk-centric culture, a way of working where risk becomes the dominant logic through which decisions are made. Under this culture, practitioners prioritize what is defensible and recordable, i.e., the safest bureaucratic decision, sometimes even when it conflicts, feels clinically or ethically right for the person in front of them. To build on these insights, I will be conducting interviews with the mental health practitioners themselves to integrate their perspectives on what influences their referral decisions and to understand how they navigate these systemic pressures in practice. Looking at communication. So to examine communication, I recorded and analyzed 15 psychosocial assessments using conversation analysis, which studies how talk is organized moment by moment. What I found was that patients often presented with intertwined social and mental health problems, yet practitioners could only address issues within the remit of mental health services. Practitioners invited patients to share their views, for example, by asking what support they felt would help, which on the surface aligns with person-centered collaborative care, but like a tailor constrained by preset patterns, their apparent flexibility was shaped by what the system could realistically offer. Practitioners used a range of subtle communicative strategies to steer patients towards available options. For example, options were often presented sequentially, with the first explored in significant detail before others were introduced. A conversational design that gently guided patients towards the most feasible option, the first one, balancing empathy with systemic constraint. Next, I'll triangulate these findings with field notes and clinical records to examine how decisions are shaped before and after the assessment and how they're represented in documentation, since records and not conversations are what travel across services. In the final component of my PhD, I am conducting longitudinal interviews with patients at 1 week and 6 months post-discharge to trace what happens next. Preliminary findings from the 1 week interview show mixed experiences. For some, referrals led to meaningful support, but for others, gaps opened up between what was promised and what was delivered due to wait lists, rejected referrals, or eligibility barriers. Some therefore returned to the emergency department. Those who fared better often relied on informal supports, suggesting that resilience sometimes emerges despite the system, not because of it. Understanding these three components help reveal the invisible work that mental health liaison teams do to keep the system functioning under pressure. It shows that systemic constraints lead to adaptations in practice and communication, where person-centered care is sometimes compromised by institutional demands. By making this visible, the research can inform training, supporting practitioners to communicate within constraints, service design, aligning pathways with real-world experiences and practice, and policy, especially as the MHCAS models are scaled up across the UK. Bringing these strands together, several patterns emerge. First of all, decision-making is not linear. It's adaptive, negotiated, and shaped by systemic pressures. Second, communication is both clinical but also institutional, and practitioners manage expectations while staying within service limits. And finally, outcomes depend on what happens beyond the emergency department within a fragmented system that struggles to ensure continuity of care. Ultimately, improving crisis care isn't about tailoring faster, it's about redesigning the pattern so practitioners have the flexibility and support to shape care around the person. Thank you for listening.